Hey y'all, welcome back. In this video, I'm going to be giving you an introduction into ventilators. Who gets intubated? What do you need for intubation? What is your role during intubation? What should you expect after intubation? And how to take care of your patients on vents. Okay, so let's start off by just talking about who gets intubated. So who are these people? Okay, I'm going to use a different color because I have so many colors. So first group of people is going to be your obvious group, which this is your respiratory failure. That's your like pneumonia, your PE people, your ARDS, which there's a video on ARDS. If you haven't watched it, please do. You're going to have your hypoxic people or your hypercapnia. Hypercapnia is when you have elevated CO2. Another group of people is going to be just some severe acid-base imbalance folks. Because the lungs are going to compensate in acid-base imbalances. Your lungs can retain or they can blow off more CO2. So if you're alkalotic, then the lungs are going to retain CO2. If you're acidotic, the lungs are going to blow off more CO2. And this is going to be with increasing or decreasing respiratory rate. All right. Another thing is going to be people who are hemodynamically unstable. So if you are on multiple pressors, guess what? You're probably going to get a tube. The reason why is because if the lungs are not being perfused effectively, it will lead to respiratory failure or hypoxia. And so we're going to intubate those folks, which makes sense, right? Because if you're on a bunch of pressors, squeezing off blood flow to your lungs even. So we don't want that to happen. So if they're hemodynamically unstable, that's going to be your stuff. I'm actually exporting another video right now, so that's what was just finalized. So if you're hemodynamically unstable, that's another one. People who have altered mental status. So you want to think if GCS is less than 8, intubate. So we're intubating for airway protection. That's your airway protection, okay? So person comes in, they're obtunded, they are at risk for aspiration, they can't protect their own airway, they're going to get intubated. So that's going to be the difference between somebody who's on BiPAP who needs to get intubated and somebody who's on BiPAP and isn't going to get intubated. If they are able to protect their own airway, then we're good to go. If they're not, then we got to put a tube in them, okay? Anybody who dies on us gets a tube, code blue, okay? And the last group of people are going to be your post-op patients. Some of these people who maybe they have a bowel surgery or they have an open belly, etc. This varies facility to facility, but various post-op patients will just come out intubated, especially if they plan on going back to surgery. They're going to get intubated. They'll stay intubated because when we do general anesthesia, the patient will get intubated anyways. So post-op patients. So that is going to be your people who get intubated. They may have one of these things. They may have all of these things. But this is just going to build your case on whether they need a vent or not. Okay, so that's your who. So let's get into what if your doc says, okay, we're going to intubate, get the stuff. Well, do you know what stuff to get? I'm going to tell you what to get. And I tried to make this list as small as possible so that way you could easily remember. So by no means is this all you have to get, but it's a majority of what you have to get, okay? Or the big things, like say you have an emergent intubation. This is going to be, what do you need, all right? So your doc, maybe they come in, they're like, let's tube right now, right now, right now. They're pressing on you. This is what you're going to make sure you get. Make sure you have O2 and suction in the room. Make sure it works, okay? O2 and suction. You need your ambu bag. you need and our facility, we have an airway box, which has the ET tube in it. It has the lubricant, it has the stylet, all the stuff that you need, the actual like things are in there. You're also going to get a glidoscope, because what if this is a difficult airway? All right. The glidoscope, basically what it is it is a laryngoscope, but it has a camera on it. So you can look at the screen and it shows you the end of that blade. So if you have a difficult airway, get your glidoscope. Other people, they would have a bougie, but our docs like the glidoscope if it's a difficult airway. Okay. You're going to need RT. They're going to bring the vent. And the last thing you're going to need are your drugs, okay? These drugs, you have 2 drugs that you need. You need I'm making sure you can see this. You need a sedative and you need a paralytic. Everybody varies on what they like to use. My docs, they like etomidate and rocuronium. So when you're giving these drugs, you want to remember to always give the sedative first before the paralytic, because we're not mean. An easy way that I remember this is you want to date them before you rock their world. Okay. So those are the things you absolutely need, okay? Other things that you should think about getting. Let's see, maybe an NG tube, restraints, oral care kit, ABG supplies, right? Etc. Okay, those are just some other things that you can get, but they're not necessary. These things you have to intubate. So you should get these things. You make sure that that stuff is at minimum what you have, okay? Everything else, you can get another nurse to help you get all that stuff. Obviously, if you have time, if this is planned, get as much stuff as you know you will need for after intubation. So let's talk about what we need to do during intubation. What is our job and what orders to expect afterward, okay? So what's my next color? I want to do blue. So during intubation, we're going to talk about during and after, okay? So during intubation, what's our job? We got 2 jobs. One is we need to administer meds. We talked about the order, but we administer medications using closed loop communication. So what that means is if my doctor tells me, all right, we're ready, we're ready to go, go ahead and give your meds. I'm going to say, okay, I'm going to give the etomidate. I'm giving 20 milligrams of etomidate, and I'm pushing the 20 milligrams of etomidate. 20 milligrams of etomidate given. All right, perfect. Doc says, great. Now go ahead and give your paralytic. Okay, I'm giving 50 milligrams of rocuronium, and I'm flushing 50 milligrams of rocuronium given. Boom. You use closed loop communication. I knew exactly what you were doing the entire time. So administer meds using closed loop communication. This is going to be when the physician tells you to. The next thing is you're monitoring vital signs, okay? So common vital signs that are going to change. They're going to desat, okay? If they do this, then we need to bag them. The reason why they're desatting is because they're probably not breathing. They're too sedated and paralyzed to breathe. So the RT is going to bag them. Their heart rate can drop. Their heart rate drops. We need to probably give them a dose of atropine. Okay. If their BP drops, this is predicted because we're giving them a sedative and a paralytic. So maybe we're going to give them IV fluids. Maybe we're going to start some levo, etc. So if before my blood pressure is already soft, I'm going to tell my physician and say, hey, doc, do you want me to have some NS ready, some albumin ready, you want me to have some levo ready, etc. All the docs will tell you exactly what to do. So I kind of talked about during before telling you the actual setup. So before you actually start, we're going to get all our supplies. The patient's bed should be pulled away from the wall so the physician can be at the head of the bed. And we're going to lay the patient flat, pull them all the way up in bed. All of our supplies is ready, vents ready, etc. So then this is our job during. As far as blood pressure, if you don't have an A-line, you're going to cycle the BP Q5 minutes at least. Okay, this is what we do at our facility. That may change across if you're not from the facility I'm from when you're watching this. Okay, so that's our job, is to monitor vital signs, administer medications. Okay, so now let's talk about what we're going to do after intubation. Okay, so the tube is in. What we need to do after the tube is in is we need to confirm placement. Okay, so after we confirm placement, we're going to do this a couple ways. First thing we're going to do is end tidal CO2 or CO2 detector. At our facility, we have a CO2 detector. We can attach the tube, and that attaches to the ambu bag. When we bag them, if it turns yellow, that means CO2 is present. That means we're in the lung. If it doesn't turn yellow, then there's no CO2 present. That means we're in the esophagus. You will know if you're in the esophagus also because you're going to be blowing a bunch of air into their bowel, and likely they're going to start producing a bunch of gas. Okay, so end tidal CO2 or CO2 detector. The next thing we're going to do is we're going to auscultate. Okay, we want to hear equal lung sounds on both sides. We're going to see equal chest rise, bilateral chest rise. The last thing we're going to do to confirm placement is a stat chest x-ray. Okay, get the portable x-ray there as soon as possible. We confirm placement. Other orders we're going to need are orders for restraints. We put that tube in. We don't want it coming out. Okay, my docs always tell me, if you let that tube come out, guess who's putting it back in? Not me. It's going to be you, aka me. So restraints. Other thing we're going to need is a sedative drip. Okay, so at my facility, options are propofol, love that drug, Precedex, Versed, fentanyl, and ketamine. Okay, so one of those or multiple of those can be used. Okay, the last thing that we absolutely need are vent settings and an ABG. The ABG is going to be done 30 minutes after being on vent. It's going to take at least 30 minutes for that patient to acclimate to the settings that you are giving them, okay? So what we're going to do is make sure that after they've been on the vent 30 minutes, they get an ABG. At my facility, the RTs get the ABGs. At your facility, the RNs may do it. Whoever gets the ABG, and we adjust our vent settings, okay? If you don't know how ventilator settings affect ABGs, don't worry about it. We're going to be talking about it a little bit more in vent modes and vent settings the next video, so you can look at that one, okay? So this is what we need to do at minimum afterward. Other little things that we may need to do. Maybe they're going to need a central line. Maybe they're going to need an A-line. Maybe we're going to bronch now, okay? Maybe they're going to need to go to CT, okay? They're probably going to need an NG tube or an OG tube, and they're probably going to need a Foley, okay? So other things that you may need, prepare for them. If your physician has told you before all this, let them know. Or if the physician tells you, get stuff for a central line, A-line, we're going to do the whole 9 yards, yada, yada. Get all your stuff, bring it close by. We at our facility have a line cart, so if you're going to place a line or an A-line, get the line cart. Tell RT at our facility gets the bronch supplies. And then after, we'll probably need to go to CT if it's ordered. So just have that stuff ready. We're in charge of placing the NG tube in the Foley. So just get your supplies. If you know what you're going to be doing afterward, just get as much as you can. Okay, but if not, don't worry about it. So you can leave the room and it's all good. Okay. So that is after intubation. The next thing I want to talk about is what could go wrong. Okay, so adverse events. This is during intubation or after intubation. Big complication is aspiration. The way we prevent aspiration before, if possible, if they have an NG tube, connect it to suction. So because when we lay them flat, pull them up in bed, sedate them, paralyze them, and we trigger their gag reflex, guess what? They're going to vomit, and if that vomit gets into their lungs, they've aspirated, they can develop massive sepsis, and we most definitely will have to do a bronch afterward. Okay, so the other thing that we do to prevent aspiration is just having suction available. So aspiration's a big one. Hypotension, which we already talked about how we would combat that. The tube is in the wrong place. So this could be the esophagus. This could be the right lung, etc. Okay. We want to, the problem with the tube being in the wrong place, obviously if it's in the esophagus, then their patient's not ventilating, but if it's in the right lung, that's going to put them at risk for a pneumo, okay? Because we're delivering a bunch of air and pressure to only one lung. So then it's going to damage that lung, cause trauma, and it'll pop, and then we're ventilating them and that air is just escaping into their pleural space, which is not good, okay? Trauma, we try not to, but you know, they're difficult intubation. And they could code, okay? Because if we don't get that tube in, we're bagging them, they brady down, they become, you know, hypotensive, they could code, okay? Afterward, ventilator-associated pneumonia is an issue. They're gonna be lying flat, so they can develop pressure injuries, malnutrition, DVT. They can also develop a stress ulcer. So afterward, we're doing our infection prevention stuff. We're getting them started on nutrition, turning them, giving them anticoagulation or putting them on SADs, and then they always get some kind of ulcer prophylaxis. So H2 blocker or a PPI. All right. So let's talk more about after the patient's ventilated, how do we take care of these guys? What are the little things? What are all the little nursing things that we need to be doing? So maybe we didn't intubate them, but we have a vented patient. How are we taking care of them? So the care of them. So some of these things are going to include oral suction. At my facility, it's protocol. We do this Q4 hours or PRN, okay? We're going to do the ET tube suction. Same thing, Q4 hours or PRN. We're going to change the tube position. Is it on the left, middle, right? We do this Q4 hours. Usually the RT at my facility does this, but you just want to make sure you do that. That's going to prevent breakdown in their mouth. We're going to be doing oral care, Q4 hours or PRN. We're going to be turning them Q2 hours if we weren't already. The head of bed is at 30 degrees, okay? We're going to be doing our early mobilization protocol. So basically that means we turn and then we're going to put them in reverse Trendelenburg. This is going to allow for the blood flow to go towards the bottom, towards their legs. And so whenever they eventually need to get extubated and get out of bed, their body's already used to or acclimated to blood flow being towards their legs whenever you're just lying flat. That's why it's much harder for you to get up after all this. So Other things we're going to be worrying about weaning, so awakening trials, spontaneous awakening trials, spontaneous breathing trials. We'll talk about these in a separate video as well. And those are the big ones. Those are the big things. We already talked about their stress ulcer prophylaxis, DVT prophylaxis, they're getting nutrition, all that stuff. So that's the minimum stuff. As far as documentation, we'll talk about documentation for this since we do that. But make sure just like you're documenting all of this stuff, okay? So that is the end of your introduction to vents. In the next video, we're going to be talking about vent modes, vent settings, and how we can alter our vent settings to fix our arterial blood gas, okay? So thank you so much for watching. If I don't see you in the next video, I hope you have the good rest of your day. Thank you so much. Bye.